Okay, thank you. So yeah, we'll start with just some brief introduction so we all know who everyone is. So I'll go first. I'm Chloe. I'm the UK trial manager based at the Bristol Trial Centre, University of Bristol. So you probably have and will hear a lot from me, and then also Leah.
Hi, I'm Leah and I'm the Deputy Coordinator working with Chloe at the Bristol Trial Centre.
Thanks, Leah. And then we do have Annie, who's our administrator, works with us as well. So you'll probably hear from Annie. Mark.
Hi everyone, Mark Edwards, Prof of Anaesthesia in Southampton. So I'm acting as the UK Chief Investigator for LOLIPOP, working with the Australian team.
And then I'll just go around in order of my screen for the site team. So Melanie.
Hi, I'm Melanie Maxwell. I'm an anaesthetic consultant at the Norfolk Norwich and PI for the study.
Thank you. Gemma.
Hi, I'm an anaesthetic ST6 registrar, hoping to be associate PI for the study.
Great, thank you. Jane.
Hi, I'm Jane. I'm a clinical research practitioner working on the delivery team.
Thank you. Ricky.
Hi, I'm one of the research fellows at the Norfolk Norwich and hopefully doing the associate PI with Gemma at the same time.
Great, thank you. Mina.
Hi, I'm Mina Youssef. I am a consultant breast surgeon at Norfolk Norwich, and I'll be leading the breast surgery part of the trial.
Great, thank you. And Deirdre.
Hi, I'm Deirdre. I'm a research nurse, delivery on the delivery team. Oh God, sorry, I've just got a cramp.
Oh,
sorry, just got a cramp in my leg. Oh yeah, sorry.
That's right. Thank you.
Yeah, I work with Jane. Yeah.
Great, thank you. And then you said we're waiting for Caroline. What role will she play in?
So Caroline is another anaesthetic consultant who is going to be delivering as well.
Thank you. Great, thank you. I shall share the slides, hand over to Mark, and we shall begin.
Great stuff, thanks Chloe. So welcome everyone. So this is going to be your site initiation visit for the LOLIPOP trial. LOLIPOP acronym for long-term outcomes of lidocaine infusions for post-operative pain. The trial, as I think we discussed in our feasibility calls, was originated from the ANSCA group, Australia New Zealand College of Anaesthetists Trials Network. Obviously a very big group that's led a lot of very successful perioperative trials over the last decade or two. They invited us to participate and contribute some NHS data, which we were very keen to do. So the agreement was that we would recruit 1,000 of the 4,000 overall sample target for the trial. And we won some funding from the NIHR to help us do that in the UK. So the trial is sponsored by my employer, University Hospital Southampton, and was supported very ably by the team at the Bristol Trial Centre. So next slide just takes us through the overall aim of the trial. As I say, we'll just whisk through this because I'm sure you're very familiar now. So we're looking at lidocaine infusions. I know at your site we're not going to be looking at overnight infusions as is the case really in pretty much all other sites apart from Belfast in the UK actually. So intraoperative and into recovery lidocaine infusion, and we're going to see if that has an effect, a positive impact on reducing moderate or severe chronic post-surgical pain 1 year after planned breast cancer surgery. Okay, so the next slide just takes us through the patient group we're targeting here. So the inclusion criteria from a surgical point of view are very broad. So it's all adult females undergoing primary surgery for a breast cancer. So we don't include any recurrences on the same side, but if it's a primary operation for known or highly suspected breast cancer, then they can be included, whether it's more breast conserving surgery or whether it's full mastectomy, and we can include patients having unilateral or bilateral surgery, and obviously including auxiliary components to their surgery as well. We can also include patients who will be having simple reconstruction, sort of tissue expander implants, or very straightforward sort of perforated flap, that sort of thing. If they're having a very simple reconstruction at the time, that's okay. And And alluding to the sort of the safety aim of the trial, we're really only targeting the slightly fitter patients, so ASA 1 to 3, excluding anyone that's got really very severe systemic comorbidity. And that's continued in exclusions. We have a number of exclusions really to try and make the lidocaine infusion as safe as possible, knowing that it's going to be metabolized in a predictable way, that the patient's not going to be particularly prone to cardiac side effects, that sort of thing. So there's a few comorbidities, a few other drugs that can affect the metabolism. The beta blockers probably is the most common one that comes up as an exclusion. They can't be included. The full list is in the protocol. The key point about the comorbidity is that you don't need to do any additional investigations just for screening for the trial. So it's information that has been picked up during routine preoperative assessment that you'll be looking at. So if they weren't going to have an ECG as part of their workup because they're young and fit, you don't need to do it just for Lollipop, for example. And then the other exclusions are really just things that would confound the results a little bit. So if they've got pre-existing chronic pain at the site of surgery, or again, if this is repeated surgery at the same site, then we don't include those patients. Okay. So next slide just sort of takes us through the overview of the trial, and the green stuff is everything up to the point of surgery. So screening and approach, we'll talk through how you're planning to run that locally in a moment, but suffice to say there's a variety of approach points that have been written into the protocol, so it's quite nice and broad. It doesn't write you into a corner in terms of the only way you're allowed to approach patients. It can be in person, or it can be by telephone with having had written information and so on. The key thing really is to make sure that any sort of decision making about consent has been done before the patient attends for surgery. They can, in theory, sign their physical consent form on the day of surgery, but you don't really want that to be a kind of discussion and decision making point. You want that just to be literally physically signing the paperwork. So if you're contacting them by phone beforehand, make sure there's a follow-up call so you can really get their decision and there's no questions looming on the day of surgery. And that obviously allows you to plan your intervention day a lot more easily as well if you know for definite the patient's going to be going for it. Once they're in and you've got consent, randomization takes place, and you get some baseline data from the patient, and then the randomization system obviously gives you a vial code. You go and get that vial code from wherever you're storing it, and then move into the intraoperative phase. So that's a case of liaising with your intraoperative team. So the anaesthetist, the surgeon, going to team brief is a good plan, just so you can discuss that the patient's in the trial, what you're going to be looking out for, how you're going to handle other local anesthetics that they might want to use. And then when the time comes, get the vial and draw up the medicine, prime the pump, program the pump, get it checked with the anaesthetist, hand it over to them, and then they'll start it when the time comes. And from a research team point of view, there'll be some intraoperative data collection. You obviously don't need to be around during the whole operation, but just bear in mind that, given that your source data will be right there, it's good to kind of get that data pretty soon after the operation's finished. So perhaps if you're in recovery with the patient, you can get that. And obviously if there's any scribblings on the anaesthetic chart that aren't very clear, you can go and clarify those. The other thing, which is a bit of a top tip, is you'll find perhaps some of your anaesthetists using remifentanil in a particular way with an infusion pump that makes it a bit hard to find out what the total dose of remifentanil that's been given is. And that's much, much easier to do there and then. So if the anaesthetist is going to use Remi, ask them to, before they switch off their remifentanil pump at the end, ask them just to note down what total dose ended up being given. It's not a total deal breaker, but it's just a bit of a nuisance. It'll flag up as a database query if you don't get that information there and then. Fine. And then when the patient's in recovery, there's obviously a bit of data collection there, and particularly doing the list screen, looking for local anesthetic toxicity. The infusion runs while they're in recovery, and then as soon as they're clinically ready to move on from recovery, the infusion can stop. The maximum time it will be running for in recovery is an hour. Or if they've had particularly long surgery and the syringe, the 50 ml syringe finishes, that's it. The trial intervention is over. You don't try and refill the syringe. And then after discharge, follow-up is very straightforward. Anything that is patient reported will be collected automatically. So the central system will automatically send an email alert to the patient, ask them to log into the online database and record their answers to the the sort of the pain and the quality of life questionnaires. The only ones you'll hear about to chase up are the ones that haven't responded to a couple of prompts from the centralized system. So you might have to phone the odd patient, but mostly it'll be done centrally, which obviously saves you a huge amount of time trying to track down patients by phone and, you know, bother them when they're at work and that sort of thing. There are a couple of data points that will need a brief notes review just to look for other treatments that they've had and readmissions and that sort of thing as well. Overall, you know, the post-discharge follow-up should be pretty light touch on the whole. General experience on the ground is that, you know, it's a nice study. It runs well on the day. It's not too onerous. Assuming the patients are getting through theatre in good time, nobody's having to stay too late. It's pretty straightforward. So any initial questions on trial overview? Hopefully you've had a chance to look at the pre-SIV training videos and so on. Any questions or concerns at this point about what we've gone through so far? Hi. Yusuf, if you want to come in.
Hello?
Hi there, yeah, I can hear you.
Hi, Mark. Thank you very much for that. Just a couple of questions. First about the procedures that are included. So you mentioned simple reconstruction. This you give an example of implants or expander. So that's fine. What about oncoplastic procedure like therapeutic mammoplasty or chest wall perforator flaps, volume replacement, and the JEP flap reconstruction? Thank you.
I believe so. Perforated flaps are okay. They're in. Anything where I guess it's disconnected and reconnected. So DEP flaps are not. They're not included. I think just because of having sort of multiple surgical sites, which kind of puts them in a slightly different category in terms of post-operative pain and chronic pain risk and so on. And any delayed major autologous reconstruction, if that's a definite plan at the point of them going into the surgery, then we exclude those as well, because if we know they're going to have a second surgical hit for sure during that first year of follow-up, then that could confound the results as well.
Thank you. That's helpful.
Okay. Right, if there's nothing else, then we'll crack on.
Thanks, Mark. So just a bit of a trial update for you all. So obviously this is an international trial running across Australia, New Zealand, Hong Kong and the UK. So in Australia, they have 18 sites open and 599 participants recruited. New Zealand have 92 recruited from 3 open sites. Hong Kong have 352 recruited from 3 sites, and here in the UK we've got 84 participants recruited from 7 open sites. So as Mark mentioned, we this SIV is designed on the assumption you've watched the pre-SIV training material. So we kind of want it to be a bit more light touch and interactive. So we're not talking at you the whole time. So if there's anything we kind of don't cover that you want a bit more detail on, please do give us a shout. But so assuming you've kind of watched the screening, consenting and randomization training videos, we're just going to have a bit of a discussion about how you see things working at your site. So could you sort of let us know who you envisage will be identifying and approaching patients? And feel free to just shout out. You don't need to put your hands up or anything.
So I think we've sort of broken that part down into, that's going to be more for Jane and Deirdre to be speaking to the patients on the phone. Initially, we're hoping that the breast surgeons in the clinics will hand out some information leaflets, so the patients already have some prompting about the study. And then following that, once we have looked at the sort of waiting lists and who's coming to theatre, approaching a couple of patients on the phone, as I say, probably Jane and Deirdre, that bit, in order to speak to them, see if they're interested, and then a second phone call if they are interested and they've had time to read it through, or perhaps they haven't received the information sheet and we need to post that out to them to see if they're interested in becoming involved. So yeah, that's the first answer to the question, I believe.
Yep, I That's great, thank you. So then following on from that, obviously if patient's happy to take part in the trial, obviously day of surgery can be a busy time. Have you thought about sort of your plan for the day of surgery? Obviously randomising needs to happen on the day. You need to make sure you've got your like vial collected and prepared and everything. Yeah, have you had sort of discussions about how that will work on the day?
Yes, so I think the on the day stuff is going to be Gemma, Ricky, Caroline, and I, or combination of, not all four of us. So yeah, once we we're not picking the first patient on the list, so it'll be the second or third to give us enough time because of pharmacy opening times. So yeah, randomise them pretty much as they're not quite as they're being sent for, but a bit before that, and then yeah, one of us will nip down and get the drug. I'm thinking that should be fairly straightforward, having consented them, of course, earlier in the day.
Okay, great, thank you. So your plan is to store the IMP in pharmacy?
Yes.
Yeah. Okay.
We've got no facility to do it in theatres.
Okay.
But we're one site. I know in when we went to one of the previous meetings, I think other hospitals had problems with multiple sites. But yeah, we're one site, so getting it from the pharmacy is not going to be difficult.
Okay, great, thank you. And then this is not really something to think about initially, but sort of when you're comfortable with the trial, and in the swing of how things work, and it's all processes are streamlined and working well. Have you thought about the potential of having 2 Lollipop participants on the same theatre list? Do you think that's something that might be possible in the future or not possible?
Yeah, I think it's certainly possible. I don't think, to be fair, we've particularly thought through the logistics of that. It can't obviously be 2 consecutive patients because there's only 1 pump. But yeah, I mean, it's certainly possible. Yep,
great, thank you. So yeah, just a couple of points we kind of just mentioned here for future when you do possibly consider it is, yeah, so as you mentioned, we would advise having a patient in between 2 Lollipop cases to allow that pump to become available. But also there is the option to, so if you did have 2 consecutive patients, there is the option to, once the pump is in the mils per hour program, yeah, you can then switch to a normal clinical pump rather than the Lollipop pump to free up that the Lollipop pump for the next patient.
Okay.
But yeah, definitely wouldn't advise it to begin with. Obviously, get yourselves familiar and just doing 1 on the list for now, and then once you're comfortable, if you did want to sort of increase recruitment, then there are some options there for you.
Okay.
So yeah, we've got quite good representation on the call from all specialties, but yeah, we just sort of like to check, have you sort of had conversations with anaesthetic surgery recovery staff at your site? Are they all aware and supportive of the trial?
So surgeons, yes. We've had a chat with we're quite a big department, so we haven't spoken to every possible anaesthetist. We've spoken to sort of one of a couple of the main ones who do it quite a bit, and they're both happy with that. We haven't had much discussion with the recovery nurses, no.
Okay.
I don't anticipate that being a problem, but we haven't spoken to them.
Yeah. Just on that note, so we do have sort of a slide set we can provide to you to like run through with the recovery nurses. This a slide set that Mark uses at his site, and there's just a bit of localization to fit your site practice. So you can, we'll ping those over after the SOV. And you can use those to sort of raise that awareness. We do also have an anaesthetist slide set. So anaesthetists who so they're just the attending anaesthetist on a Lollipop case. They won't be doing anything further sort of research active wise or like Lollipop wise. They don't necessarily need to be on the delegation log. So in that case, we've just got a simple slide set that we ask that they either run through or you present to them. However, if it is an anaesthetist who's going to be a bit more involved, for example, signing off eligibility and things like that, then they do need to do a bit more in-depth training and be on the delegation log.
Yeah. Okay.
So yeah, we can send both slide sets over to you.
Thank you. That'd be really helpful.
And have you had a chance to use the staging database, which is a test database that looks exactly the same as the real one? Just allows you to sort of familiarise yourself with the system, and if so, have you got any questions from that?
I've watched it on the videos. I haven't played with it myself. I don't know about the others. Ricky, have you, or
No.
Gemma? No.
No, I haven't.
No, I watched
No.
the videos like you said. I didn't see there was a bit you could click to go on. I didn't know that was a thing.
No, I didn't know that. Yeah, I didn't see that bit either. But yeah.
Okay, I'll double check.
Sure.
So we usually get a link. We send you a link basically to activate your account on the staging database. I'll double check that's been done, and if not, we'll send it over. Sometimes it goes into junk folders, but I can't imagine it's gone into all of your junk folders. But yeah, I'll double check if you've been sent them, and if not, we'll ping them over again.
I think that has come, actually. That now rings a bell. I think I may have. I think what I've done is I've done the login, and then I've deleted it, thinking I've done it, not realizing there was a other bit to it. Yeah. I think I have received that. But if you can send it again, that would be helpful.
Yeah. Okay. Yeah, it's just to familiarise yourself. Have a go at randomising a patient, unblinding a patient. So yeah, you can just have a practice before getting on the real thing. Okay, thank you very much. Any other questions about screening or consenting, randomising at all?
Not from me, I don't think.
Yep. I'll hand back over to Mark then for a couple of slides.
Sorry.
Great stuff.
Oh, sorry.
Sorry, could I just ask about the eligibility? You were saying if the anaesthetist is not involved in signing off the eligibility, can I ask at what stage that form needs to be filled out, presuming it's a form?
Signing off eligibility?
Yeah.
Yeah, so at the moment the protocol states before consent, I think, but we have got an amendment going through that will change that to before randomisation to hopefully give a bit more leeway, because we're aware, it can be quite tight timeline, so hopefully that will give a bit more flexibility.
Okay.
Thanks. So just talking through the dispensing sheet. So this is quite central to just sort of steering the care on the day of a lollipop patient. So this gets generated by the randomization and database system. Once you've gone in to enter a patient, you'll put in the data that you need for the system to generate a lean body weight and to give it various other details as well. It'll then churn out this dispensing sheet, and on that you'll see the study ID, the vial ID that you need to get from the cupboard for that patient, and then it'll have a little rundown of what it's expecting the trial intervention, the bolus injection to be, and the mils per hour infusion. And that allows you to cross-check that against what the pump has calculated it will plan to give, because that obviously is running to its own program, which should be well aligned with this as well. So there should be basically the same between the two. The other things on the dispensing sheet, you can see the blue box around it, relates to parallel local anesthetics that the teams might want to give in addition to the trial drug, which may or may not be lidocaine, obviously. So these are at a lower total dose than they normally would be for clinical care, just to give a bit of a safety headroom and avoid the risk of local anesthetic toxicity. These are a kind of an either or. For bupivacaine, the doses are the same for levobupivacaine as well, and then ropivacaine is given there as an option as well. So, for example, if somebody wants to do a regional block or to do surgical wound infiltration sort of with a high volume, that basically gives the total dose in milligrams that can be given for that individual patient. And the other thing to say is that the Australian team have actually created a little Excel spreadsheet. So if you wanted to convert that into how many milliliters of whatever concentration of local, that can be made available to you as well, just to have available on an iPad or a laptop, ready to consult, just for total clarity. And then the red box has got the spaces for the cross-checking. So the two cross-checks that you would do, the first one is getting two people to cross-check the correct vial has been taken out of the cupboard, and getting them to sign. And then the second cross-check is one research team member, whoever has drawn up the vial into the syringe and loaded it into the infusion pump, and has programmed the infusion pump, pausing during the setup to basically get that cross-checked by the anaesthetist to make sure they're happy with what they're giving as well. The one very minor detail, which you might notice in the future if you're eagle-eyed, is that occasionally there's a 0.1 mil per hour difference between what comes from the spreadsheet, what comes from the dispensing sheet, and what gets displayed on the infusion pump screen during setup for the rate at which the bolus dose is given. I think that's just due to differences in the way that these numbers are rounded. But essentially, you can probably do the maths in your head and realize that a 0.1 milliliter per hour rate for an infusion that's going to take about 5 minutes is basically insignificantly different. So if you do notice that very minor difference, then that's okay to sign off as being the same and cross-checked. But if you do see a major discrepancy between the two, probably something has gone wrong with either putting the data in the database or with programming the pump. So it's worth checking what's happened there. Okay, then the next slide, we just look at the pump in a bit more detail. So it's not quite the right screenshot because this has gone through the full setup on this pump, but essentially during setup of the Nexus pump, you'll get the opportunity to have those figures that are on the dispensing sheet displayed. So you basically just turn the pump on. The only two options here will be either mils per hour or lollipop. So you obviously select lollipop, you put in the lean body weight, and at that point it will say, right, we're planning to give such and such for the bolus and then such and such for the mils per hour. So you pause at that point, don't press any other buttons, leave the pump as it is. It won't alarm or switch itself off. It'll just sit there quite happily until you're ready to talk with the anaesthetist and cross-check those numbers with them. And once that's done, you press OK and confirm what's going to be given, and hand it over to the anaesthetist to connect up the syringe. And then when they're ready, once the patient's asleep and they've got the airway secured, they will press start when they feel they're happy to. Just to flag, of course, that the Australasians are using the slightly older BD pumps. They're just called the PK. The ones that have come out now are called Nexus. They're pretty much the same. They've got some very sort of minor updates, but in terms of usability and how they function, they're pretty much the same. But doing that pause halfway through programming is something that you need to do with the Nexus. The older pumps, you could actually fully confirm all the settings and then go back and review them midway through, but you can't do that with the Nexus. So you just need to pause halfway through the program before you confirm. But yeah, they're very easy to use. A lot of anaesthetists will be very familiar with these because they might use them for total intravenous anaesthesia. I'm not sure, Mel, if these are the ones you have for TIVA at your site or you use something different.
We used to have them, actually. We don't have them anymore, but I think most of us are familiar with them.
It's actually sneakily quite a good thing to have different pumps for your TIVA because our API, when she went into theatre a couple of months back, she said you have to be quite careful just to make sure it's positioned away from the anaesthesia pumps, because if somebody isn't really thinking they want to go and change the rate of propofol or something, they sometimes accidentally press some buttons on the lollipop pump. So actually having a different brand pump is no bad thing. And from a slightly cynical viewpoint, no one will pinch it if it's not what we're used to using. Indeed, yeah.
Yeah. It won't find its way into another theatre.
Yeah, exactly. In fairness, they have got stickers all over them, and they would struggle to use them for an anaesthetic because it'll just come up with the lollipop program rather than any anaesthetic programs. So yeah, should be impossible for them to be misused. But yeah, things do walk. It's fairly routine for local medical engineering teams to want to just check new equipment in, perhaps put it on their sort of equipment database, do a pat testing or whatever. So that's fine, but they have been set up and checked by the Southampton team initially, so they're pretty much ready to go once your local team are happy. Okay. Any questions on that? Sometimes get asked, does the patient need does it need their own Venflon just for the infusion? They don't. It's really up to the discretion of the day's anaesthetist. They might, depending on whether they're using total intravenous anaesthetic and how many lines are on that giving set, that sort of thing. You can either put it on the same cannula, or they could use a dedicated cannula if they've got a lot of things already running in, for example. It's really up to their discretion about how they want to do it. As long as it's on a non-return valve and it's all nice and safe, then we're happy.
What we commonly do, we use a lot of Nexiva cannulas. They've got 2 ports to them, and we do a lot of TIVA, virtually exclusively TIVA, actually. So we're likely to have that running through one of the ports, and then I guess the local can run through the other.
Sounds good. Yep. Don't think I've ever come across those actually, but they sound very nifty. Great. Okay, let's move on.
Thanks, Mark. So yeah, now we'll move on to a bit of safety in the trial. So on the screen now you can see a summary of the study drug infusion stopping criteria. So this table can be found within the protocol, but we'll also provide you with a printed laminated copy in your study startup pack. And we just sort of advise that this printed table is sort of remains with the patient whilst the infusions run in, so at all times in theatre and then into recovery as well. Just outlines you know, when the infusion should be stopped and when there's cause for concern, essentially. And then Mark mentioned the LIST tool earlier, so the lidocaine infusion surveillance tool. So this tool is intended as a rapid aid to identify clinical signs or symptoms that may indicate the patient is starting to develop lidocaine toxicity. And obviously, if any of those symptoms arise, then it would lead to you stopping the study infusion. So there's 5 symptom questions that the patient's asked, and then 7 clinical signs are assessed. So for day case participants, you should start completing the tool when the patient arrives in recovery, so within 15 minutes of their arrival, or when the patient is sort of awake enough to have a conversation with you. And then you should then ask the patient the 5 questions again once they meet the criteria for step down to reduce monitoring or leaving recovery. So if at any point the participant answers yes to 2 or more of the questions or has any signs or complications at any time, then you must stop the infusion. After the infusion stopped, if the patient is sort of otherwise well, then and stable, you should repeat the LIST tool hourly until either all the symptoms and signs have resolved or 2 hours have passed, whichever comes first. If that's the case, they're stable, symptoms are resolved, no need to unblind. If the patient remains unstable once you stop the infusion, obviously that's more concerning. You should initiate rapid or urgent review by however it works in your site, either the anaesthetist, the emergency team, critical care team. Obviously make them aware that the patient's a LOLIPOP participant and has possibly had lidocaine, so is possibly experiencing lidocaine toxicity. If there is suspected severe lidocaine toxicity, follow the AAGBI guidelines and unblind the participant. If intralipid is indicated, then don't wait for unblinding to start giving that. All suspected lidocaine toxicity events should be recorded on our form 13, so that's CRF form, sorry. And these events need to be reported to the UK sponsor at your earliest opportunity and within 24 hours of that event happening. So the kind of take home from this is the LIST tool is there to kind of prevent any emergencies happening. Hopefully, it's quite non-specific. If there's some symptoms and the infusion's stopped, if the patient's fine, no reason for concern after the infusion's stopped, don't unblind. If then if the patient remains unstable or gets worse, unblind is I think the take home from that. So any questions at all from the LIST tool? Nope. So yeah, if you did need to unblind, so some examples when this is required is sudden unexplained loss of consciousness, tonic-clonic seizure, life-threatening arrhythmia or cardiovascular collapse. Obviously, do so. After randomization, you have the ability to unblind on the database for 36 hours. So it's important if the participant's surgery date changes, that you remember to also update that surgery date in the database to allow you that 36-hour window to unblind. Anyone with an account on the database will be able to unblind, but also recognize in an emergency situation, anybody needs to be able to unblind this participant, that you will have a generic unblinding login. So how that works is the username will be sent to the lead research nurse. They'll then create a password for that. And just to note, that should be a generic password because it's going to be written down on a piece of paper and available for anyone to use. We'll provide you with the unblinding guideline you can see on screen now. Again, that should be kept with the patient at all times once the infusion's running. just because you've got an account on the database doesn't mean you need to use that to unblind. The quickest way really is to get your phone out, scan the QR code on the unblinding guideline, and use the generic login to unblind. So yeah, just because you've got an account doesn't mean you need to use that in an unblinding situation. And then if the participant is unblinded, you will need to complete our unblinding CRF form 11 and also the suspected lidocaine toxicity form 13. So is there any question? Nope. Safety endpoints. So there's some safety endpoints listed in the protocol. These are sort of documented within the CRFs and reported if there's sort of cause for concern. So there's a bit of overlap with that table for stopping the infusion I showed you a few slides ago. The infusion should be stopped if any of these events arouse cause for concern or can't be resolved following treatment. So most of these are sort of considered expected reactions and don't require expedited reporting, so we'll capture them within the CRFs. But if the nature and severity of any of the event is inconsistent with the information about the drug in the reference safety information, then obviously we will need to report this. So protocol breaches. So CRF form 10 is our protocol breach form. So this should be filled in and entered onto the LOLIPOP database. Unfortunately, in the UK, we do have a second sponsor required form. So that's a paper form that you'll complete and email to the two emails you can see on the screen there. I will say, don't worry if you forget. Like if you have a protocol breach and you just remember to do the CRF form, like that's fine. We'll remind you to do the second form. So if you can remember to do both, great. But if not, we'll give you a prompt anyway. In the protocol, there's a few examples of protocol breaches, so infusion related and non-infusion related that you can see on the screen there. But in the UK, obviously any deviation from the protocol counts as a protocol breach. The one I'll just pick out on the slide here is the non-infusion related, so open label administration of lidocaine in excess of permitted amounts. So if it's sort of realized that more than the permitted amount of lidocaine has been given before you start the LOLIPOP infusion, then we say just don't start that infusion. If it's picked up whilst the infusion's running, then we ask that you stop the infusion, because obviously we don't know if that patient is then receiving lidocaine and could potentially receive a toxic amount. And then a bit of a safety reporting summary. So obviously the safety reporting video is quite a chunky one, so I don't go into too much detail here. But just to note that the summary of medicinal product characteristics is the reference safety information in LOLIPOP. And then there's just a summary table there. Again, I won't go through this because you'll be able to look back on it, but just explains which forms each event should be recorded on. Obviously, if it's a serious event or any safety issues, they do need to report it to sponsor within 24 hours of you becoming aware of the event or of that event happening. So is there any questions at all on anything safety related? Nope, fab. And my last slide before I hand over to Leah. So just a bit of a quirk with this being an international trial, I guess, is that basically since the UK joined the trial and started collecting data, we've realised that there's a difference in dexamethasone dosage used between Australia and the UK. So reviewing this, the Australian team have decided that we're going to report the Australian doses because obviously they've already got a chunk of patients recruited and we need consistency in the trial. So it's a bit of a mouthful for me to say, but you can see on there if like the UK use 3.3 milligrams of dexamethasone sodium phosphate, you would record it as the Australian 4 milligrams of dexamethasone phosphate equivalent. That is noted in the CRF manual, so we'd advise maybe first couple of patients have that CRF manual next to you to help you with completing the CRFs. But again, if you did, great if you can remember this. If you can't and you put in the UK dose, it's fine. It'll be flagged as a query and you'll just be asked to update it anyway. So again, like great if you can remember. If not, we'll give you a prompt anyway with that. So yeah, just a little bit of a don't know, say glitch, that's not the right word, but with this being an international trial. So I'll hand over to Leah now to go through some follow-up.
Thank you. So on the screen there, we've just summarised the follow-up time points in LOLIPOP. So there's 3 time points at 3 months, 6 months and 12 months. So most of the follow-up is a patient-reported questionnaire, and that's done at all 3 time points. We collect that on REDCap, which means that the questionnaires are sort of automatically emailed out to the patients at the time points, and they get reminders as well. Obviously, if the patients decided they don't want to do it online, that's fine. They can opt to do it over the phone with the research team instead. So in that case, the reminders and things would just get sent to the research team to remind you to call the patient. We've also got a little bit of data collection from the medical notes at 3 months and 12 months, and that data is actually collected on the main database as opposed to the REDCap database. So again, like we were saying, to sort of have the CRF manual handy, it's quite good to have it handy for the follow-ups as well, just because it will remind you which data you need to enter where, especially if you're doing the phone calls as well. It might be a bit confusing, sort of what you're putting where. So yeah, just to note as well that the 12-month follow-up is the primary outcome for the study. So it's really important we try to collect that, even if the patients miss their 3 and 6 month follow-ups. We'd still like you to try to collect the 12 months. Are there any questions on the follow-up so far?
Can I just ask something? This may be just a sort of specific question more to Norwich, but I just wonder what are other hospitals doing in terms of, do they have a sort of a single email address that you would contact? I'm just thinking, let's say the patient doesn't respond at 3 months, so we're contacted. Who gets contacted? I mean, is it a specific? Would it be me as the PI, or are people having a, like a generic lollipop at NNUH sort of? Is that what other trusts are doing so that we can all access the same inbox?
Yeah, so how we'll set up the REDCap is for those patients who are doing the questionnaires by phone. Those reminders will get sent to one email address, and we are either using an email address that you guys already have that covers the team, or we can set one up for you, which is like an Outlook group, and it basically we just put everyone's email addresses into that want to be included, and then that sort of puts out one email address that we put in. So yeah, it's essentially like a trial mailbox, like you're saying.
Right. Okay. Thank you.
Great. Next slide, please. Cool. So just to note as well, as part of the follow-ups, patients are asked to calculate their total daily dose of pain relief medication at 3 and 12 months. We recognise that might be a bit tricky on your own, so we have provided a participant guidance document for doing this. And this is available within the questionnaire if that's being completed online, so they just get a link next to the questions where they can access that. But if the patient's opted to complete the questionnaires over the phone, then we're just mentioning this because you might want to post out a copy to them in advance of the follow-up, or send it out by some other means. Yeah. Next slide, please. So we've got another round now of just some discussion points to kind of round off that section. So just, a few scenarios here of what you would kind of do in this situation. So what would you do if a participant was randomized on the day of surgery, but then they had to have their surgery postponed?
So you need to change the date of it to the new surgery date because of the 36-hour thing, don't you?
Yeah, that's right. So a couple other things to note. If it's been postponed for more than 30 days, you will need to recollect consent and also the baseline data. But within the 30 days, you don't need to do that.
Okay.
And also, obviously, when they get randomized, they get allocated a specific vial. So that can just be used when they come back for their surgery instead. But we do just say to try and draw up that vial at kind of the last minute in case of situations like this, because if they've already been randomized, the vial's been drawn up and the surgery gets postponed, then that vial can no longer be used, obviously, at a later date. So they wouldn't be able to continue in the trial. Okay. So next scenario is what the procedure would be if a participant had a seizure in the recovery area.
So stop the infusion, treat them obviously as necessary, unblinding to see what they've had done, and then fill in the adverse event forms and as well.
The unblinding form is number 11 and
Yeah.
the lidocaine toxicity number 13.
Yeah, I think that's pretty much covered it. Nice. Cool. And what would you do in the unlikely event that the pump failed during the bolus infusion?
So if it fails for the bolus, you'd have to stop it, and you would not give them a second. You would stop it, as in withdraw them from the study.
Yeah, so you wouldn't need to withdraw them from the study. You just wouldn't restart the bolus, and you'd restart
Did
the
they just go onto the
infusion
mils
on
per hour or
just
something
the
then?
mils per hour. Yeah, that's right.
Oh, just
Yeah,
go in the
that's
mils
what
per
I'm
hour. Oh,
saying.
sorry. Sorry. I thought it was, okay.
And then you would have to just record that as a protocol breach.
Oh, breach.
Yeah,
Okay.
but they would remain in the study. Okay. And just the last one, probably for the research team, what would your process be if a participant wasn't responding to the 1-year follow-up questionnaires?
Well, we would contact them ourselves
Try.
on the phone.
Yeah, try again, usually.
Yeah, I mean, we usually sort of say like 3 times is a good number of attempts. And yeah, phone calls we find are really good if a participant isn't responding to like postal or email questionnaires. Usually getting hold of them by phone is the best way. So yeah. Great, thank you. Next slide,
Sorry, Leah,
please.
just to add on to that. You can collect the 12-month time point up to 15 months after surgery as well, so you've got quite a big window, because obviously that's quite an important time point there.
Yes, thank you. Okay, so just to explain what to do next after today's session, you'll need to finalize your training on your training log. So we've got a Microsoft form that we're using to record this. I'm not sure if anyone's already done this, but we've got a link available there and a QR code, but I think we've probably sent this to you previously as well. So that's where you just record all the kind of training modules you would have watched before this and also today's session. And then most of you also need to register on the delegation log after that. So that's being done on a electronic system called Mango. And yeah, you register on there. And then once your sort of registration's been activated, you'll be sort of invited to log into that and add Lollipop to your account, which is where you complete your actual delegation log. All the kind of Lollipop registrations come to us first to check over, just to make sure like your GCPs are in date and things like that. And then once we've sort of checked that, it will then go to the PI for that sort of PI sign off that you usually have on a delegation log. And you'll get a notification by email to do that. The other thing is just Melanie, for when you're registering and you add your tasks to your account, we just say that for PIs, they should sort of add all the delegation log tasks just to show that you're having oversight over everything. Obviously, you're not performing those tasks day to day, but just to, yeah, cover that oversight.
Okay.
Okay. Next slide, please. It sounds like you're aware of this already, but that's just a note to say that we're registered on the Associate PI scheme, so happy to accept registrations for that. Okay. And I'm now going to just share the site setup checklist, which will just sort of run through that quickly and give us a bit of an idea of where we're at. Okay. So CVs and GCP certificates, as I kind of mentioned, those get uploaded when you do the delegation logs. So that will be covered when you do that. Protocol agreement page, that's a sort of PI sign off page. I'm not sure we've had that yet. Could be wrong.
I think we might have it from,
Oh, from
SLV was
before?
rescheduled, yeah. I'll double
Okay.
check, but I think
Yeah, have a look. I should have a quick look in the files, but I might have missed it in an email.
Let me know if it's not been done.
Sure, thank you. Yeah, we've already spoken about the training log and delegation logs there to be done still. MNCA, I think that's one of the ones I've seen we've got the details for, and that just needs to be sent off for signatures now, so that's in progress. How are things progressing with local approvals? Is that sort of happen alongside the contract, or?
Yeah, I think that's pretty much done as far as I understand it. We had a sort of short meeting about things yesterday. I think I think that should be, the wheels are turning, or even maybe it's completed.
Okay, yeah, well, we haven't had the CNC letter through yet, but hopefully
I think
that's
Danny
coming
is
soon.
literally doing it sort
Okay,
of
great.
as we speak. Yeah.
Perfect. So ISF checklist, I think we still need that from you. I'm sure we'll send like a list of actions through after this that'll have things like that in it. I'll take these two off. You've said that the storage of the study drugs arranged, that's going to be kept in pharmacy. In terms of the pump being sent out to you, so once that contract's in motion, we'll arrange that to be sent out. So that action's sort of with us, and then for you to confirm it's been received and checked by the medical engineering team. We may need to resend some staging database logins, is that right? So yeah, do that. And then a couple things, you probably already got these, but 50 ml syringes that can be used in the pump, yeah, and
Yeah,
some
we have those.
intralipid in theatre, yeah. Localization details, they've been provided. I think we just need to send those over to you. I think we just wanted to double check that we had some details right. So we've got, for the sort of named local contact, we've got your name, Deirdre, is that right? To go on like the PIL and things like that.
You're on mute, Deirdre.
Sorry. Yeah.
Yeah.
Yeah. Okay. Yeah. Yeah.
Okay. Yeah. And the hospital name, is that just Norfolk Norwich University Hospital?
NHS
Yeah.
Foundation Trust. Yeah.
Cool. So we'll get those sent over to you. So that's correct. So CRFs are available on the website if you haven't downloaded those already.
Okay. Yeah, we haven't. Yeah.
Okay. Yeah, just let us know if you're having any trouble. We can send those over. And yeah, I think we've mentioned these, and some of these are outstanding. So yeah.
just to mention with the ISF, we don't mandate if it's paper or electronic, so it's up to you at site if you want to keep an electronic or a paper site file.
Cool, thank you.
Thanks, Leah. I won't reshare the slides because the last slide was just our contact details, and we'll send you a copy of the slides so you'll have those to hand. Is there any questions at all from anything we've covered today or not covered today?
Not from me, thank you.
Nope. Oh yeah, no questions then. Just thank you all for your time, and yeah, sounds like things are progressing. So we'll look forward to hopefully getting you green lighted very soon.
Great. Thanks very much.
Thanks everyone for your time.
Thank you.
Look forward to getting you going.
Bye.
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 Bye.